Hi, this is Mena. Today I will be discussing radiographic finding for patient with osteochondroma. The patient chief complained the reason for the examination. Patient 11 years old. The patient complained of the bony lump for 1 month. Today he comes in to October 13, 2017. Pain or discomfort, gross disturbance, deformity, massive swelling. For the significant medical history, no trauma, feeling a mass or lump in the left knee, a lump in left knee. His doctor ordered left AB knee and lateral knee, only 2 views. As our side protocols, we do it standing. Signs and symptoms associated with the condition are bony deformity, hard immovable, painless pulpal mass, limited normal function, and movement care caused by osteochondroma growing slowly and inwardly. For the radiographic procedure, AP weight bearing, we use the 8x10 lengthwise, erect, standing, feet straight, head, knees straight, weight disturbed evenly on both feet. CR perpendicular to the IR to the midpoint between the knee joint at the level of ½ inch distal apex of the pedal. SID 40 inches. As we see here, osteochondroma. For AB, it's a little rotation because should 1/2 of the proximal fibula will be superimposed by the tibia. For the lateral knee, patient unaffected side. For the lateral knee, patient on affected side, knee flexed 20 degree, unaffected leg, and the knee placed behind to prevent over rotation. CR centered to 1 distal to medial epicondyle. SID 40 inches, collimation 4 side. As you see here, markable osteochondroma. That's the lateral. It's a little bit, as you see here in the lateral, it's a little bit rotation because you can see the femoral condyle not superimposed. For the radiologist report, skin marker placed in the medial aspect of the knee in the area the pulpal abnormality. Correspondingly, there is single pedunculated osteochondroma measuring 13 mm projecting inferiorly from the medial aspect of the proximal tibia. There is no fracture or post-traumatic deformity. The joint space are perceived. There is no evidence of arthritis or osteochondral defect. Osteochondroma is an overgrowth of a cartilage. It's a surface lesion that arises from the surface of the bone and continues with the medullary cavity. Most often, it affects the long bone in the leg. Most commonly, the locations distal femur, proximal femur, and proximal tibia and proximal humerus. Technique used for the osteochondroma increase the technique. Most commonly, it involves the lower femur or upper tibia. As you see here in our case, the proximal tibia, and is capped by growing cartilage attached to the skeleton by the bone stem. But it can occur, however, any bone in which endochondral ossifications occur. The lesions can be sessile or pedunculated. Sessile means the base is wider or associated with the higher risk of the malignancy. But in our case here, as we see, pedunculated, usually grow away from the joint. Osteochondroma often arises at the site of tendon insertion. The direction of the growth follows along the line of the tendons. Usually find these around the knee joint, above or below the growth plate. It usually gets bigger during a growth. It does have cartilage cap, which does get bigger as the leg gets longer. Treatment included surgical resection, which is removal or cutting away. In the most cases, treatment consists of careful observation over time. Your doctor may want to take regular X-ray to keep track of any changes in the tumor. Indication for the surgical removal of the tumors are the same as for solitary osteochondromas: pain, pressure on nerves or blood vessels, and the large gap. In this unique case, I have learned increased technique for the osteochondroma pathology. I have learned more information about osteochondroma, and I can see it from the radiograph. Also, provided patient care, especially for young adult, shielding and collimation both sides, collimation 4 sides. Also, do not communicate physically and ask patient gently, and be friendly with him or her. I hope to deliver something good. Thank you.